My name is student Dr. Jennifer Addleman. I will be talking about some research regarding blood flow restriction training, otherwise known as BFR, and its clinical applications. Before we start, I wanted to briefly go over the goals for today's presentation and other student presentations that we will be having throughout this year. The goal of the student presentations is to discuss a topic of interest backed by research and other sources. We will discuss the topic in detail and then open up the discussion for the conversation for a deeper discussion among students and faculty regarding any clinical applications or questions we may have after learning about the topic. I will be recording the talk today, but not the discussion following. So please be respectful of all participants involved in the discussion, and there are no bad questions. So we'll go ahead and get started. First, a little bit about me and why I'm presenting to you today. So I am a first-year medical student at Toro and a certified strength and conditioning specialist through the National Strength and Conditioning Association. I have always been an athlete. I played softball until midway through high school when I got injured, but became more active in the fitness community until about 8 years ago. I went to undergrad in Davis, where I studied physiology and published research about gait biomechanics in the Human Performance Laboratory. This is a picture of the research that I was doing. I worked for a physical therapist for 5 years, coaching corrective exercises to patients and learning about movement science and kettlebell training. There's some pictures of that here as well. I actually used blood flow restriction myself and used it with many patients that I worked with. Nowadays, I work out in my home gym and climb often. At this time, I'm interested in physical medicine and rehabilitation residency with a fellowship in sports medicine. Okay, so let's get into it. Why is BFR used and why is it so important that I'm talking about it today? The problem is to optimize muscle hypertrophy, 2 to 3 days per week of moderate to high intensity resistance training at over 65% of the 1 rep max is recommended. This can be a problem for injured or elderly populations who are in need of muscle hypertrophy for rehabilitation purposes, but cannot train at this intensity, such as patients with osteoporosis or post ACL tear or total knee replacement. This is where blood flow restriction training comes in. This is the use of a tourniquet on a proximal limb for full venous occlusion and partial arterial occlusion, typically in combination with low intensity exercise. This includes bodyweight squats, light leg press, biking, etc. We will talk more about the specific protocols later, but this is what it looks like. There's this cuff on the limb, followed by a tube, and then it's attached to this machine that we'll describe a little bit more. And this is actually a video of me performing bodyweight squats about 2 years ago with the tourniquet on. So you can see I'm just doing bodyweight squats, and it's much higher intensity than it looks, especially compared to bodyweight squats. It feels a lot harder than that, and we'll talk about why. A number of studies have shown a significant increase in muscular cross-sectional area and strength changes after low intensity exercise with and without BFR for an 8-week period. In this graph on the left, we see that both cross-sectional area and strength increases significantly more with BFR than without, as a result of knee extension exercise at 20% 1 rep max intensity, which is considered low intensity. In the graphs on the right, we see that both cross-sectional area and strength increase significantly more with BFR than without during low intensity exercise at 30% of 1 rep max, which is comparable to high intensity training at 80% of a 1 rep max. So with this being the case, BFR can have immense clinical applications in rehab settings where patients need to maintain and gain strength and hypertrophy, but are unable to exercise at 80% high intensity. This slide is just to show you some examples of patients who benefit from use of blood flow restriction training. On the left, we have a patient who had an ACL tear and subsequent surgery. You can see the amount of atrophy that is occurring on the injured side. And this atrophy extends the rehabilitation process significantly, especially for athletes who need to get back to a high level of performance before returning to their sport. On the right, we see a patient with a total knee replacement. Yes, it may surprise you that we can use BFR on patients with a total knee replacement, but if you think about it, you can't really hit high intensity exercise values of up to 80% of a 1 rep max after a major surgery like a total knee replacement, but you still want to prevent as much atrophy as possible. BFR is only 20 to 30% of 1 rep max intensity, but allows for gains comparable to 80% intensity. Once the patient has enough range of motion and the initial inflammation has reduced after surgery, BFR can be immensely helpful with those hypertrophy and strength gains. Clinical use of BFR includes full venous occlusion and partial arterial occlusion, followed by exercise to fatigue. The fatigue aspect is important due to the mechanism that will be discussed later in this talk. The cuff is applied to the most proximal portion of the limb, and then the tube port connector is placed on the lateral aspect of the limb so that for comfort and to avoid kinks in the tube. The limb occlusion pressure is completed automatically. It's a test by the machine and is performed with the patient supine and still to determine the personalized training pressure. This is measured by arterial and venous flow and determines the occlusion pressure required to achieve full venous occlusion and partial arterial occlusion. This is really important because if the pressure is too high, then blood supply can be cut off completely, and then there's risk for vascular injury. But if the pressure is too low, then too much arterial supply can cause pooling, which can be painful. There are two types of BFR technology. One of them is manual and the other is digital. Manual is use of a manually applied cuff or rubber band for partial occlusion. This is easily applied and really cost effective, but it doesn't self-calibrate or maintain a relatively constant pressure with movement, resulting in less than full venous occlusion during muscle contraction or everything gets smaller, and then possible ischemic injury with excess pressure when everything gets bigger again. The digital unit measures and determines the limb occlusion pressure, and it otherwise known as the pressure to fully occlude venous return and partially occlude arterial supply. So the digital unit also self-calibrates to maintain a relatively constant pressure with movement. So when you're contracting that muscle and then relaxing it, it'll still maintain a relatively constant pressure. This can be better personalized for limb occlusion pressure, and it prevents ischemic injury. Best practice use of BFR is 2 to 3 days per week for 10 weeks at low intensity. So that's about 15 to 30% of a 1 rep max. The pressure is at 50 to 80% limb occlusion pressure, which approximates 140 millimeters of mercury for the thigh and about 90 millimeters of mercury for the upper arm. The repetition scheme for the exercise of choice, for example, squats, lunges, leg press, is 30 reps for the first set, and then 15 reps for 3 additional sets, each with 30 seconds of rest in between sets with the tourniquet left on. The exercises should be performed with a 2 to 4 second eccentric and concentric movement, and the timer is set for 8 minutes. So if the participant is finished before the 8 minutes are up, then it's recommended that they keep the tourniquet on until the time runs out. And if the participant isn't done yet, then the tourniquet is still removed at 8 minutes. There are additional protocols such as cycling with the tourniquet on for 8 minutes, but I won't be going into as much detail on those options. So what are the mechanisms behind BFR technology? Well, we know it works, but we are still trying to prove how and why. And so this is the theory. It's called the metabolite theory. And we're going to be kind of going into how this works and break it down into each of its constituent elements, followed by some of the research that supports this theory. First, we'll talk about the hypoxic environment and subsequent increased lactate. So lactate buildup occurs as a result of anaerobic muscle contractions. The muscle burn after anaerobic exercise, such as at high intensities, is a result of the acidity of the environment due to local hypoxia. The goal of BFR is full venous occlusion and partial arterial occlusion in combination with low intensity exercise. So this potentially creates a hypoxic environment with a buildup of oxygen depleted blood. If this is all true, we should see a lactate accumulation in the blood after BFR compared to low intensity exercise, which we do see that. And it's comparable to high intensity training, even though the training load is only 30% compared to 80% of 1 rep max. The next question is exercise required for the lactate effect? A study compared BFR with no exercise to BFR with low intensity exercise. Only the BFR and exercise group demonstrated a significant increase in lactate production. So this effect is not simply due to the application of a tourniquet. Exercise is required. Do manual leg wraps work the same? Well, in another study, subjects performed exercise with leg wraps and were compared to a control that didn't use leg wraps. There was no difference between the groups, concluding that the study does not support the use of knee wraps as a mode of blood flow restriction in order to get this lactate effect. Once we know there's increased lactate production, we can investigate the expected effects of the lactate. First, we expect to see increased muscle fiber recruitment. So more lactate has been shown to result in additional motor unit recruitment required for continued contractions. So IEMG, which is seen here, is an identifier of motor recruitment. So IEMG increases at lower intensity exercise with BFR application. So increased motor unit recruitment, and it's actually similar to the high intensity exercise group. Next, we'll discuss growth hormone release. So accumulation of lactate has been shown to result in growth hormone release, which is consequently seen after BFR training. Growth hormone allows for recovery through collagen synthesis, not always reflected in hypertrophy or athletic performance, but is shown to increase tendon stiffness and cross-sectional area. Again, we compare this to the tourniquet only, low load exercise without the BFR, and low load exercise with BFR, and we find a significant increase in growth hormone release with BFR training. Due to the increase in growth hormone release, we would expect to see increased IGF-1 and satellite cells converted to muscle fibers. Satellite cells are precursors to skeletal muscle cells, and IGF-1 responds to increased growth hormones and recruits satellite cells for more muscle fibers. Not only did the satellite cells show to proliferate after BFR, they were actually observed to be incorporated into the muscle fibers significantly more than low intensity exercise without BFR. When the muscle is taken to fatigue, as we talked about is recommended in the protocol, we expect to see an increase in mTORC1 production. mTORC1 has been shown to trigger cellular growth and protein synthesis. Taking a muscle to fatigue will activate mTORC1, and elevated mTORC1 is still identified after BFR training for over 24 hours, which is normal for high intensity training, but not normal for low intensity training. And again, just another reason why BFR with low intensity is similar to high intensity training. We'd also expect to see an increase in myostatin production or a decrease in myostatin production when the muscle is taken to fatigue. Myostatin has been shown to block myogenesis, muscle cell growth, and differentiation. So myostatin was shown to decrease significantly after BFR training and high intensity training, but not after low intensity training. We'd also expect to see increased collagen synthesis in bone due to the increase in growth hormone release. And we see here that increased growth hormone was shown to decrease healing time significantly in closed tibia fractures. This study was done independent of BFR, and no BFR trials have actually been published at this time to demonstrate the same findings, but there is a potential for a similar effect in BFR training since we talked about that growth hormone release. Finally, and most significantly, we see proximal gains and full body hypertrophy after occlusion of only one limb. Let's think about that for a second. Does that mean if I occlude my left leg that my whole body will increase in muscle cross-sectional area? A study showed that wearing one tourniquet on a lower proximal limb resulted in significant gains in squat, bench, pull-ups, sprints, and counter movement vertical jump power compared to control. This highlights the idea that BFR may have a full body metabolic effect and has many other implications for rehabilitation. There have been a number of questions asked regarding blood flow restriction technology and potential risks of use. So the first I'll be talking about is blood clots. Studies have found no increase in markers of thrombin generation or intravascular clot formation after BFR with exercise. Additionally, they found that TPA was significantly increased after BFR and high intensity training. TPA is a fibrinolytic protein that allows fibrin clots to be broken down. So from the current research, it appears that blood flow restriction does not pose a risk for blood clots. As we age, there is decreased arterial compliance, which is the ability of a blood vessel wall to expand and contract passively with changes in pressure. Resistance exercise may increase arterial stiffness in the elderly, but BFR actually may be a solution to that, as some studies actually report improved arterial compliance after BFR training. However, this hasn't been consistent in the literature. Muscle damage is common in high intensity training, and this type of damage appears to be lower in BFR than high intensity training due to the inherent lower intensity of the training. So a study compared delayed onset muscle soreness, otherwise known as DOMS, after putting both legs to failure, one with BFR and one without. The rating of perceived exertion are similar, but the delayed onset muscle soreness shows to be significantly lower in the BFR leg than in the free flow leg. And again, I wanted to mention that BFR is at a significantly lower weight and intensity compared to high intensity training, but it actually had a similar rating of perceived exertion. So this is by no means an easy way of training, but it allows you to be at a lower intensity while you're training. Ischemia reperfusion injury is injury to the muscle from prolonged tourniquet time, which is typically seen in surgery and is associated with full occlusion of the limb and tourniquet times of 4 to 6 hours. Prolonged hypoxia results in cell death, and the subsequent reperfusion of the release of the tourniquet pressure further damages the cell structure through the release of reactive oxygen species. Increased measurements of reactive oxygen species have not been demonstrated in the BFR literature. There is likely no reactive oxygen species due to the tourniquet only applied for approximately 8 minutes, if not less. Nerve damage is a potential risk due to the high pressure and stretching of the underlying nerve structures, but variable cuffs are adjusted to the shape of the limb to enhance comfort and decrease risk of mechanical shearing. And a wider cuff actually disperses the pressure over a greater surface area to minimize the risk of injury. Furthermore, like we talked about before, the personalization of digital cuff pressure minimizes the risk of nerve injury due to the fact that it actually allows it to fluctuate in addition to the way that your muscle is fluctuating in its size. So what is the future of BFR? BFR has the potential to be immensely effective in clinical rehabilitation, especially in injured or elderly patients who cannot train at 80% of their 1 rep max. It is already used in some performance physical therapy settings and decreases rehabilitation time due to the increase in muscle hypertrophy or maintenance of muscle hypertrophy in patients at risk for atrophy, such as post-ACL surgery. Platelet-rich plasma injections are commonly used injection therapy to accelerate the healing of tendon, ligaments, and other slow healing injuries using peripheral hematopoietic progenitor cells and platelets. Exercise with BFR causes a significant post-exercise increase in these peripheral hematopoietic progenitor cells and can be used prior to preparation of PRP injection to increase the healing potential of the procedure. This is huge for sports medicine, as we now have a way to increase the healing factors in a procedure that is already commonly used. Finally, BFR can be used for patients with chronic disease. Studies show that high intensity exercise can be difficult to achieve with chronic diseases, and BFR can allow patients with chronic disease to perform low intensity exercise with the benefits of high intensity exercise. Thank you so much for listening. I will now open up the discussion for any questions or comments, and I'm gonna flip through my sources as well.